All right, so next let me introduce Maham Rahimi. Where is he? Come on up here. He's our new partner. He's not even started yet. So this is, we put him to work. We gave him 2 talks. This is like free baseball for us. We put him to work and we don't even have to pay the guy at this point in time. So he's going to basically tell us, what's your first talk? It's going to be, first of all, endovascular management of carotid and vertebral stenosis, and then we're going to hear about carotid body tumors.
Thank you. By the way, VSAP 4 just came about. Definitely use it. Figure this out first. Okay, you heard about the ACAS trial, and basically what you need to know is about the asymptomatic patient. They studied it for 5 years and tried to see medical management using aspirin versus carotid endarterectomy, how they affect the patient. They decreased the stroke risk from 11% to 5%. For the symptomatic patient, they followed the patient for 2 years, and they saw that it decreased from 26% to 9%. So pretty effective comparison to medical management, just aspirin. These are some of the exclusion criteria for the 2 study: surgical, comorbidity, age, and lesions. This will not be in VSAT or ReCite. Now, advantage of carotid stenting. In vascular surgery, you always have 3 options: either open or endovascular or medical management. And it is your job to determine and select the right patient. If you select appropriately, your procedure most likely going to work, plus your pre-op planning. The carotid stenting usually benefit patients that are symptomatic, and they are not appropriate for surgery. They don't pass the eyeball test. They have some kind of congestive heart failure. I will cover some of the indications. Small incision over the groin for catheterization. Sometimes they use brachial, but my preference would be the groin. And avoidance of cranial nerve damage, although it has been done. I don't know how, but it has been done and reported. And less cardiac event. So again, you have 3 options as a vascular surgeon: open surgery, endovascular surgery, and medical management. In reading carotid artery stenting literature, you have to be careful as who put the money for the research. Some of them has done by the companies like, I'm not going to example one, but Safari is one of the examples. You just have to be careful reading these data. Although the data said that in their primary endpoint, which was a stroke, MI, and a stroke, and death, there was no difference between the 2. Now, what are we worried about carotid artery stenting is the stroke, the embolic event during the stent deployment, or most commonly when you deflate the balloon from predilation. The devices can be used is a balloon. You can see the pictures on the right side of the screen, or you can use distal filtration, or you can use proximal balloon occlusion. There are many devices out there. Again, as a vascular surgeon, not only you have to select the patient right, but you have to pre-op planning. It's very important to know the anatomy of the patient before going in. For instance, what type of arch they have, how much tortuous or calcified. Is there a free-floating thrombus in there? This is probably will be in the VSAP, VSite, the type of the aortic arch, type 1, 2, or 3. And basically, you can run a parallel line outer and inner curvature of the aorta and see how many blood vessels are underneath of it. The impact of the stent, most often self-expandable, closed cell if it has a thrombus or it's a very ugly ulcerative plaque. Non-tapered bare metal stents is used. We have a lot to learn from carotid stenting and our past experience. I think better stents will come, and carotid stenting will get better, but it takes time. There are other trials for symptomatic disease that can be used, EVA3S, SPACE, or ICSS. Since time is limited, I would like to focus on the CREST trial. I think this is a good trial. This is what I quote for patients when I talk about carotid artery stenting. And they looked at symptomatic, asymptomatic, and carotid stenting and carotid endarterectomy and randomized it. What they found out from the endpoint result of the stroke, MI, death, there was no difference. However, when they looked at specifically at the stroke, advanced age has a significant stroke comparison to the carotid endarterectomy. Interestingly enough, I think it was last year in JVS, there was a publication to take a look at the CREST trial and the angiographic imaging of the carotid, and they tried to find out why the complication is high. It's like any other blood vessel, like if you look at a long lesion, several lesions, usually your endovascular procedure is not going to work well. What showed in, I think it was Wesley Moore in UCLA that looked at the CREST trial and angiography, what it shows if you have a 3 millimeter or less and you have just one lesion rather than multiple lesions, the exact word is carotid artery stenting as safe as carotid endarterectomy. So short lesion and just one lesion would be beneficial. Now, what are some of the guidelines? If the patient is symptomatic, if the patient has a high risk, usually recommended to go ahead and do carotid stenting, and it's a viable option. Medical management, aspirin reduce your thrombosis, statin reduce your restenosis. There was a study done that they take a look at the patient with a statin, without a statin, again ACAS, and NASA trial was only aspirin as a medical management. But if you add statin, it decreased from 5% to 1% the stroke risk, which is very significant. The recommendation for blood pressure control is 140/90. That's something you will see in a test. For the pre-op of the patient for carotid endarterectomy and stenting. We covered this. Some of the side effects of a statin, you obviously know, leg cramping, myositis, elevated hepatic function panel. And we covered aspirin. There was a study, you might see this in a test, a chance trial, basically. Look at how many days it will take until you see the effect of medicine. It was 90 days, 3 months is a magic number. And the stroke reduction on aspirin alone was 8% versus aspirin Plavix was much higher, 12% reduced it much better. However, there was more bleeding risk, and it recommended for a carotid endarterectomy that you take your time for closure and perhaps a drain, although always makes me nervous put a drain close to prosthetic. Now, what's the take-home message? If a patient does not pass the eyeball test symptomatic, do carotid stenting is a reasonable option. What are some of the high-risk patient? Congestive heart failure, type 3 or 4, ejection fraction less than 30%, recent MI on a stable angina, radiation, previous carotid endarterectomy, or contralateral occlusion. I have a few more minutes. I wasn't sure if I'm going to have time. I'm going to talk about a vertebral artery endovascular a little bit for you. For what you need to know is you're going to treat patient with vestibulo-basilar insufficiency. If they have diplopia or ataxia or whatever is in the brainstem. If there is insufficiency to them, you might think about looking at your vertebra using ultrasound or CT scan. Most common, some people will probably tell you in later lectures about the anatomy of the vertebra, V1, V2 in the foramen, V3, V4. V1 in the beginning of the before entering the foramen is the most common site for atherosclerotic disease for vertebra. There was a Switzerland study in 2014, JVS, that they studied 73 patients. They did not use any embolic protection device in their study, but it is recommended if it's more than 3.5 millimeter vertebral artery, go ahead and use the embolic protection device for vertebral intervention. And they used balloon expandable coronary stents, and they had 5% complication being transient, ischemic attack, hematoma, allergic reaction. No patient died, and the primary patency after 7 years was 87%, which is very good result, basically. For carotid stenting and also for vertebra, usually the recommended is to oversize 1 to 2 millimeter.